Hi there, everyone. Um, Thank you for being with us tonight. Before we get started, I'd like to welcome you all to our webinar this evening. My name is Elizabeth Errico, and I am the Executive Director of the Children's Mental Health Resource Center. For those of you who are new to CMHRC, welcome. We are a national nonprofit that provides guidance and resources for the early identification and management of mood disorders, bipolar disorder, and its newly identified phenotype dubbed fear of harm. And we do this work with children, families, and with the providers who treat them. To fulfill our mission, we provide a multitude of services for families as well as practitioners and educators. These disorders are isolating for children and their families, and they are difficult to treat without the proper information and resources. So our goal at CMHRC is to break down this isolation and to provide the information that everyone needs in order to be able to provide effective treatment and accurate diagnoses for children and adolescents. You can learn more about our programs and services on our website, cmhrc.org. If you're interested in any of them, you can make an appointment for a free consultation directly from our website. We work extensively with providers, mental health, physical health, as well as educators in order to ensure that you have the resources, information, access to the latest research, and in essence, the materials and support you need to be able to provide maximally effective care for children and teens who are often misdiagnosed. Our services include diagnostic consultations, that's for both families as well as providers, school advocacy, community advocacy, our toolkit, which has a special version just for providers so that you can have your patients and clients tracking their mood, their symptoms, their medications, their diagnoses, and then you can access that information in real time so you know how they're doing when they're not in your office with you. We have education programs, memberships for families and providers, and we have transition support when it's time for a client to seek care from a new provider. Tonight with me is my colleague, Jennifer Sevick. She is our clinical coordinator here at CMHRC, and she is going to be monitoring the Q&A and the chat during the presentation. She's going to be collecting and sort of organizing all of your comments and questions as we go through the presentation. She's not going to be responding to them during the presentation, but we're going to kick off the discussion afterwards with whatever has been added. So please feel free as I go through the presentation to add that information. And the reason we're doing it this way is that tonight we're doing things a little differently than we have in the past. If you've been with us before, tonight's going to feel a little different. We're going to have a presentation that's only about 25 to 30 minutes long. And then we're going to invite anyone who's comfortable to turn on your camera, turn on your microphone, and join us for a roundtable discussion of the content. We have some case studies that we're ready to present. If we want to talk about specific cases, we'll be open to having you as providers talk about some tricky cases that you might be facing, and sort of giving you a taste of what it is that we do in our professional discussion groups, which meet monthly. They're for our provider members to come together and talk about the challenges and successes that they've had in their practice treating children and teens who have mood disorders, bipolar disorder, and fear of harm. So let's get started with the presentation. I'm going to turn my camera off just so that you can focus on the slides and not on me, and I will turn my camera back on once we get into the discussion. So first, our learning objectives for tonight will be broken into two sections. The first being during the presentation, we are going to cover what clinical intuition is, why clinical instinct is important in conceptualizing client issues and in treatment. We will address the therapist's role in treatment and the role of the concept of intersectionality as it relates to the ethics of clinical practice. Then during the discussion, we will talk about how to use clinical intuition and instinct in practice. So let's get started with examining what clinical intuition is in the first place. The earliest idea of clinical intuition or instinct actually comes from Sigmund Freud. He was writing about this like 115 years ago, and he created the first term to describe the influence of the provider's feelings on the therapeutic process. And he called this countertransference. It was in contrast to the concept of transference, which was an essential part of the analytic process during which the patient unknowingly transferred feelings that they had about someone in their past or current life, and they projected them onto the blank slate of the analyst. Countertransference, therefore, described the feelings that were brought up within the physician. And as Freud put it, it was a result of the patient's influence on the physician's unconscious feelings. Now, as the 20th century progressed and new theories came along to evolve Freud's concepts of analysis and psychoanalytic theory, it became psychodynamic theory, and opinions of countertransference and its role in the therapeutic process evolved as well. The psychiatrist and psychoanalyst Paula Hyman wrote, quote, "The analyst's countertransference is not only part and parcel of the analytic relationship, but it is the patient's creation. It is part of the patient's personality." This is important because it indicates an understanding that countertransference or clinical instincts are inherently from and by and about the patient, not the clinician, which framed it really as what it is, clinical data about what's going on with the patient. By the end of the 20th century, countertransference really became thought of as a diagnostic response, which was seen as having enormous clinical usefulness. Now, currently, in the 21st century, when most providers are no longer steeped in the psychoanalytic language of Freud and his psychoanalytic theory, we understand that what he called countertransference provides us with intuitive reactions and clinical insights, which are key components of the therapeutic process and help the therapist to understand the client's experience, and to understand the client's therapeutic arc. Clinical intuition is, as I said, fundamentally clinical data, information that we are getting about the client's experience and process. The tricky thing is that while Freud had this very clean definition of countertransference that he used, modern researchers struggle to agree on a specific definition of clinical instincts. Some have basically argued that it can't be defined specifically, but they can identify this kind of intuition when they see it, and have agreed sort of more generally that intuition is a sense of knowing without knowing how one knows. And we talk about intuition using terms like flashes, hunches, gut feelings, body experiences, and behavioral impulses. Now, this leads many people to believe that intuition is therefore somehow unscientific, that it's some kind of soft science and is therefore unsupportable in a system that insists upon evidence-based models of treatment, which we'll talk about more in a minute. But this perception that clinical instincts are non-scientific is quite simply not true. Clinical intuition involves a right-brained, fully embodied mode of perception and response that allows therapists to perceive and respond to relational patterns during the psychotherapeutic exchange with clients. It's the way that our right brain absorbs, processes, and understands the communications that are coming to us from our clients that are both verbal and nonverbal, that are intentional and unintentional, and that are conscious and unconscious. It makes therapy more than just an exchange of facts and skills. This relational process is necessary for making really deep changes in behavior, thought, and symptom presentation. Intuition is, on a neurobiological level, about the synchronization of neurons and synaptic pathways in the brain between two people, client and therapist, that allows them to understand one another, to experience empathy, and to bond with one another. Research shows that the activation of mirror neurons triggers the right hemisphere of the brain's subcortical and limbic systems and the prefrontal networks. The counseling technique known as mirroring, which has the counselor match posture, tone of voice, and emotional intensity with the client, does precisely this in the brains of the counselor and the client. So rather than being purely subjective, counselor intuition is born out of these neurobiological processes. Psychologist Dr. Bryce Hagedorn describes this feeling of clinical instinct as, quote, an itch in the back of your head. That small voice prompting you to take a risk and to speak to a client's situation in a way that may seem like it's coming out of left field. He goes on to say, quote, clinically, intuition is born out of experience in the profession, experience with the client, and experience with the client's presenting concerns. It's a way of subconsciously tapping into these realms and making conclusions that may not be directly observed, but rather felt. So some examples of clinical intuition and instinct hitting the provider in the moment include the following feelings. When a therapist feels tired in session, it may be an indication that the client is experiencing a depressive episode. When a therapist feels bored in session or their mind wanders, it may be an indication that the client is experiencing anxiety and rumination. When a therapist feels irritated with the client, both in and out of session, it may be an indication that the client is being unconsciously manipulative or controlling by appearing helpless. When a therapist feels despairing, as though they don't know how to help the client, it may be an indication that the client feels intense feelings of shame or is in a state of disintegration. Also related to depression, when a therapist feels angry or enraged in session, it may be an indication that the client is experiencing the aggression turned inward that Freud believed was the core feature of depression. And when a therapist feels stuck in session, it may be an indication that the client is experiencing dysthymia rather than depression. This is just a handful of examples of therapists' feelings and what it could be telling us in terms of clinical data of the experience of the client. There are many, many more. Now, this brings us to our next learning objective, to understand why clinical instinct is important in conceptualizing client issues and in treatment. As mental health professionals, we all know that we have ethical obligations to our clients. Each branch of the field, from social workers to professional counselors to marriage and family therapists to psychologists and psychiatrists, are required by their professional associations and state licensing boards to follow specific ethical guidelines. And this is a good thing. But in this day and age, we're pushed by the system, whether we realize it or not, towards believing that using evidence-based practices and manualized treatments is the only ethical approach. But we don't really look at what this means on a practical level in terms of our practice. So evidence-based practice means using a scientific approach to understanding a client's presenting issues and in designing a treatment plan that meets their needs. We can use everything from brain scans to genetic testing to blood work and more in order to do this. The purpose of it all, however, is first and foremost to help inform, individualize, and improve treatment choices for each client. The purpose of a scientific approach is not to limit us in what we can do therapeutically with our clients, but rather to have a scientific set of tools that can be used to inform, to provide additional information, and to help us really individualize the care that we're giving. But manualized treatment, which is often dictated by many of those identified evidence-based practices, is actually something different. It's essentially formulaic, and it establishes a singular path for treatment that's based on a set of skills, tools, or prescribed methods that a therapist has to learn, use, and oftentimes teach to their clients. So when the method fails, which it will inevitably do a certain percentage of the time, providers are taught by this formulaic system that it's the client who's failed, not the system. But the formulaic approach denies clients individualized treatment, which they deserve, and it sidelines the use of intuition and clinical instincts in our treatment. To quote psychologist Dr. Terry Marks Tarlow, who spent her entire career studying clinical intuition, it's really unethical for us not to include clinical intuition in our training and in our conceptualization of providing the highest service to our patients. She goes on to say, quote, if we don't tap into this side of expression and connection, we're really not making the fullest connection with our patients, and we won't be attuned enough to help them with the deep kind of change, not the superficial, not just symptom reduction, but cellular level complete transformation. That's right. Formulaic and manualized approaches that deny the use of instinct, intuition, and subjectivity, they flat out obstruct our ability as clinicians to facilitate the change our clients are seeking out by coming into therapy in the first place. It's only through intentioned attention and the use of instinct and intuition that we're really able to be in the moment with our clients, following the natural flows of emotion, energy, and nonverbal unconscious communication that's passed back and forth between client and clinician throughout session. These are necessary and essential to facilitate true understanding and true growth and change. Now, insurance. Insurance reimbursement requirements and insurance limitations on treatment. From the number of sessions allowed to the type of therapeutic interventions that are recommended, they create systemic barriers to the fulfillment of our fundamental purpose as therapists and counselors. Prefabricated methods must always be filtered through our clinical judgment and delivered with a personal touch that is individualized and informed by our intuitive understanding of what is happening in the moment with a client's thoughts and their emotions. Which brings us to our next learning objective. Understand the therapist's role in treatment. Now, the most central and fundamental tool we as clinicians have in our toolbox is the therapeutic relationship itself. Whether we are embedded in a psychoanalytic or person-centered or Gestalt theoretical framework, the work of therapy takes place within the microcosm of the therapeutic relationship that's built between the clinician and the client. This relationship is based on trust, respect, boundaries, rapport, and shared experience. But we don't start out the therapy process with all of these crucial elements in place already. They have to be built over time. And as I have often said to countless clients, I don't expect you to trust me because I tell you I can be trusted. Over time, you will experience me as trustworthy. And when you feel confident in that consistency of your experience, then you will trust me. And it is okay for that to take time. As clinicians, we need to accept that process will take time as well and realize that the initial phases of the therapeutic process are primarily about building that connection, and however long it takes is fine. Once the solid foundation has been established, the therapeutic relationship can become that microcosm. It's a safe space in which the client's outside relationships, which may not feel safe, are analyzed and explored through the proxy of the therapeutic relationship with the counselor. And within that microcosm, the client has the opportunity to practice interpersonal dynamics within that safe therapeutic session. Through that relational process of internalizing the voice of the therapist, the client is eventually able to translate their newly developed skills into the macrocosm of their lives and relationships. As clinicians, we need to trust this process and to realize that these initial phases are about building connection. And however long it takes, 6, 9, 12 months, sometimes years, is however long it takes, and that's okay. But we are discouraged from thinking like this by session limits set by insurance companies and formalized approaches that encourage note-taking in session, homework for clients, and that dictate we use skill building within a certain time frame as the determinant of therapeutic success. In many ways, modern therapy training programs teach clinicians that they're actually a form of educator. Whether they use this terminology or not, by focusing on formalized practice based in skill development, we create a hierarchy that places the therapist in the role of teacher above the client, who's the student. This is entirely counterproductive to the true therapeutic process and creates the false impression that the therapist is somehow the one in charge of the therapy. This could not be further from the mark. The role of the therapist is to be a guide and a companion, a reflection of and witness to the client's process. The client is in the driver's seat, so to speak, and determines what issues they wish to address and when. It is not up to the therapist to predetermine the areas of therapeutic work or what is an expected or desired outcome for treatment. And this is true regardless of the age of the client, whether they are 6 or 96. It is the client that determines what therapeutic work is going to be done and what the desired outcome is. Clinical anxiety on the part of the therapist leads us away from our role as a guide and witness. We cannot effectively build an honest relationship or accurately reflect back to the client their exploration, their experience, if we're caught up in anxiety about our own purpose. Training and certifications in concrete, task-oriented, and skill-based interventions taught by formulaic and manualized approaches makes us as clinicians feel more secure. When in doubt, we can point to some certification as evidence of our clinical skill. But these certifications don't actually increase clinical skill or confidence. They increase a dependence on formalized and manualized treatment practices that actually decrease a clinician's attunement and reliance on their own clinical instincts. For example, current climate of therapy is heavily focused on trauma and trauma-informed treatment. But not every client has trauma, and not every client who does have trauma wants to or is ready or able to address that trauma when they come into our office. If we push them to address that trauma before they're ready or able, we may actually be doing more harm to them than good. And our certification in trauma-informed treatment is not what should determine whether or not or when a client focuses on their traumatic experience. That certification is merely proof that we have educated ourselves on the impact of trauma and are ready to help a client address it when and if they're ready on their timeline, not ours. It's not the lens through which all clients and all client experiences should be seen. Which brings us to our next learning objective, to understand the role of intersectionality in the ethics of clinical practice. Black feminist scholar Kimberly Crenshaw originally developed and refined the concept of intersectionality. The Center for Intersectional Justice explains intersectionality this way. The concept of intersectionality describes the ways in which systems of inequality based on gender, race, ethnicity, sexual orientation, gender identity, disability, class, and other forms of discrimination intersect to create unique dynamics and effects. For example, when a Muslim woman wearing the hijab is being discriminated against, it would be impossible to isolate her being female from her being Muslim and to isolate the dimensions causing her discrimination. Or, for example, tackling the gender pay gap alone without including other dimensions such as race, socioeconomic status, and immigration status will likely reflect inequities among women. This concept of intersectionality is important in understanding the ethics of our clinical practice. When we sit in session with an individual with whom, by all appearances, we don't share any demographic categories, it's usually pretty easy for us to remember that we need to take issues of culture, race, gender, religion, sexuality, and others into consideration, and to allow the client's various identities to inform our understanding of them and their experiences. But we cannot become complacent and not realize if we've ceased to take this matrix of identity into account. And this happens most often when we see similarities between ourselves and our clients, or when we see similarities amongst many of the individuals in our client base. In these circumstances, we run the risk of making assumptions about our clients' goals and therapeutic desires. For example, if I, who identifies as a woman and a white American, sees a client who appears to also be a woman and appears to also be a white American, I run the risk of assuming that we've had similar experiences in life and that we can relate to one another based on those characteristics, while potentially ignoring the ways in which the matrix created by the intersection of each of our personal identities influences our experiences of the world. The same is true of practices that see the same type of client over and over again. For example, someone whose practice specializes in children. You may see children from a specific geographic area, maybe the same school district, and who may all have a similar socioeconomic background. But that doesn't mean that the intersections of their identities are the same and that each child can be seen through the same lens. We must remember that similarities in background do not equate to similarity of experience. And it's through the intersection of our identities and our experiences that our view of the world is shaped. When we're able to consciously let go of these preconceived ideas, we're able to embrace in the moment who we are and who we're working with and what specific needs that individual has that that person chose to come into therapy to address. Now, we're going to address our final learning objective to understand how to use clinical intuition and instinct in practice through a group discussion of the ideas that have been presented. But before we do that, I want to share with you the 2 slides which have information on the works used in the development of this presentation.